Good evening, everyone present here. I am Faraz from IGCP Group. Welcome all the participants on today's webinar. That is on very important topic. Before introducing the topic, I would like to invite our guest speaker for this webinar. He is none other than Dr. Abhidoy Verma, sir. And let me share some of the achievement of sir. Sir is Associate Professor, Department of Endocrinology, Index Medical College, Indore, Madhya Pradesh. And today he is going to discuss on a very important topic, that is beyond hypoglycemia, a case-based guide to rational Sulfonylurea use. So taking my not much time, I would like to invite sir and hand over this session to sir. The stage is yours, sir. You can proceed from here.
Thank you, Faraz. Uh, Good evening, friends. And as Mr. Faraz has already told you about the topic today, it is basically on the rational use of sulfonylureas. We all know, friends, in type 2 diabetes mellitus, we have now lot of drugs in our armamentarium, and we still use in a country like India sulfonylureas, which are like the backbone of our type 2 diabetes mellitus treatment. So, can we have another slide? Next slide. Yes. But we are always in a fix. Which drug is better, sulfonylureas, older ones or newer ones, or the thiazolidine or acarbose, metformin, SGLT2 inhibitors, or DPP4 inhibitors. But before that, I just want to share few words that diabetes destiny is in our hands, treating physicians and making our patient aware about the ill effects of hyperglycemia by achieving a good metabolic karma. Thomas has used this term, the metabolic karma, to explain that how glycemic legacy has its effect in diabetes. And it has shown in various studies also that timely and optimal interventions aimed at achieving recommended metabolic targets do contribute to a sustainable improvement in overall outcomes in our diabetic patients. And a holistic approach of this metabolic karma encompasses diagnostic as well as therapeutic consideration at various stages of disease, whether it's a newly diagnosed diabetes, an uncontrolled diabetes with a shorter duration, or maybe a uncontrolled diabetes at a long duration of diabetes. So, the concept of metabolic karma can be used as an effective motivational tool to encourage better healthcare, seeking behavior, and adherence to prescribed intervention to our patients. Next slide, please. And when today, especially when I am talking about sulfonylureas, when we have lot of bombardment with the SGLT2 inhibitors like DAPA, and now we have empagliflozin, the DPP4 inhibitors. Still, you can see amongst major anti-diabetic agents real world uses of sulfonylureas, especially in Indian patients with type 2 diabetes, Asian patients with type 2 diabetes mellitus, was shown in this Joint Asia Diabetes Evaluation Register. And what it showed, that in Asia, including China, India, Hong Kong, Indonesia, Malaysia, where we have a lot of type 2 diabetic patients, Sulfonylurea plus metformin is still a preferred combination in about 79.5% of our type 2 diabetic patients. And sulfonylurea along with DPP4 inhibitor 22.1%. So, and when we break this use of sulfonylurea, among sulfonylureas, gliclazide was the most prescribed sulfonylurea to the tune of 46.7%, followed by glimepiride 40% and glibenclamide 8.1%. Next slide, please. So today we'll see the time to reposition sulfonylureas in type 2 diabetes mellitus, especially in Indian context, which should be a pragmatic, practical approach. Because a lot of being said about sulfonylureas that they cause hypoglycemias, they lead to beta cell depletion, they have problems with cardiac preconditioning, weight gain, etc. etc. But I would say that modern sulfonylureas are quite effective and safe in type 2 diabetes management when used as initial therapy combined with lifestyle modification and metformin. And when the HbA1c target is to reduce it by 1.5% or more. Yes, if you have zero point 0.5 to zero point 0.7 or 1% of HbA1c reduction, we can give any other class of drugs like DPP4 or SGLT2 inhibitors because they are not that potent anti-hyperglycemic agents compared to sulfonylureas. Yes, studies have shown that sulfonylureas can be even effective as a second or third line therapy also as per the patient's choice, because a lot of guidelines now they say start with metformin or metformin along with DPP4 or maybe a SGLT2 inhibitor. So after two drug, if the sugars are not well controlled, we can give them sulfonylureas also. And it is quite effective in steroid induced diabetes also. And on the contrary, as it was thought earlier, it can be used in elderly patients, renal impaired patients also, and those with long term fasting periods like Ramadan, Navratri, obviously with due precautions to avoid the risk of hypoglycemia. Next slide, please. So here you can see this is special differential mechanism of action of gliclazide versus glimepiride, where it may have some effect on ischemic preconditioning of heart, but here you can see that gliclazide has a differential affinity for this SCOR1 receptor, leading to controlled and pulsatile insulin release. And other sulfonylureas, you can see here, they have selectivity for pancreatic KATP channels, which preserves and protects ischemic preconditioning. So here you can see that with gliclazide, there is no effect on cardiac cells, but with other sulfonylureas, they may have problem with ischemic preconditioning. Next slide, please. So these are the benefits of gliclazides. So it's not only a good sugar control, but there are various metabolic and cardiovascular benefits with this class of sulfonylureas compared to other. Over pancreas, it reduces the apoptosis. So the beta cell destruction is slowed down because of reduced oxidative stress, reduced endoplasmic reticulum stress, ultimately preserving the beta cells and helping in a good glycemic control. Then we have its effect on kidneys, again There is a reduced oxidative stress, so there is a reduced albuminuria also. Over heart, as I have shown, it improves ischemic preconditioning and blood vessels. It improves the endothelial progenitors. It improves endothelial mediated vasodilation and reduces the bad dense LDL cholesterol also, giving us a better cardiovascular disease outcome. So you can see here, other than just getting sugars controlled, we have these extra added benefits with glycoside, which is a modern sulfonylurea. Next slide, please. So now we'll start with this. We get a newly diagnosed type 2 diabetic patients. Next slide. And we are in a confusion which drug to start. He is a 55-year-old male, weight 92 kgs, BMI on higher side 28 according to the Indian standards, BP is normal, A1C is 9.8, fasting sugars quite high 253, PP 374, serum creatinine 0.7, EGFR okay, lipids total cholesterol 178, triglycerides on higher side, HDL on lower side, and LDL also on higher side. So what we have to advise this patient who has newly diagnosed type 2 diabetes mellitus and dyslipidemia along with obesity, our target weight should be lesser. We should advise him to first lose weight with the lifestyle interventions. Next slide, please. And we had fixed him on continuous glucose monitoring also. You might have heard nowadays this is being used quite widely to see the glycemic patterns and the sugar control with the agents we use, so that we can correlate the action of drug and the patient's blood sugar level very well. So he was already on metformin 500 mg along with tenelagliptin and dapagliflozin as 10 mg once daily. And his Libre-Pro continuous glucose monitoring was set to a time in range between 70 to 180 mg per deciliter. And for his lipid management, he was taking rosuvastatin. Next slide, please. And we can see here that with his dapagliflozin DPP4 metformin combination, his blood sugar levels were not getting controlled because he was taking medicines as per what the new ADA AAC guidelines they say. Give him a metformin, give him a dapagliflozin because he is quite obese, maybe at higher risk of CV events, and DPP4 inhibitors also. So he was already on these two or three medications, but still his blood sugar levels, you can see on this continuous glucose monitoring, they were not getting well controlled. The sugars were coming quite higher above range, 80%, 90%, sometimes 100% throughout the day. Blood sugar levels were not coming within the time in range. Next slide, please. So what we did here, sugars were not getting well controlled, so we changed the dapagliflozin to dapa metformin combination and added a gliclazide 80 mg once daily also. And you can see here, after 17th May morning, first dose of gliclazide was given, and you can see from the first day, Wednesday 17th, you can see that 97% sugars above range. Next day only came to 19%. Third day it came to 8%. Fourth day it came to 0%. And this was continuously maintained. So, with a triple combination of metformin, DAPA, and DPP4 inhibitors, the sugar levels over 16 days was not getting control. On 17th May, when we started glycoside, the sulfonylurea, the sugar levels from second day started coming well within the timing range. Next slide, please. So here you can see all 14 days continuous glucose monitoring. So within 48 hours of addition of glycoside, the TAR improved drastically to 80% and above, and it continued to improve and sustained above 90% limits, and with time below range in the permissible limits. So there were very lesser chances of the sugars going below the range of 70 also. Next slide, please. So here we can see that how the blood sugar levels with addition of a sulfonylurea got very well controlled, and there were no significant hypoglycemias also. And then we did a C-peptide evaluation after the patient's blood sugar levels were good. And here you can see C-peptide was 1.9 and stimulated was 3.7 nanomole per liter, which are quite in good range. So there was no extra stress or exertion on the pancreas also, and thereby we are preserving pancreas, not putting them at much stress, and still getting our blood sugar levels well controlled. Next slide, please. So here this is the whole summary. You can see here sometimes only with the DPP4, metformin, or SGLT2 combination we may not be able to achieve higher levels of blood sugar levels. As I said in my previous slides, that HbA1c or more than 1.5% is difficult to achieve with SGLT2 or DPP4 inhibitors because they are weaker anti-diabetic agents, especially when compared to sulfonylureas, because sulfonylureas have shown to control the blood sugar levels from a very high range also. And this here you can see the example we have given for 1 week 10 days, the combination DPP4 and the SGLT2, but after addition of glycoside from 48 hours onwards we started getting very good blood sugar control. Next slide, please. So this, as I was saying, the sugars were well controlled and it was maintained. Main thing here you can see that at the end of 3 months follow, HbA1c from 9.8 came down to 6.5. So well within the range, well within the target HbA1c of less than 7. And the lipids were also very well controlled. So here you can see the benefit which we saw with initial glycoside addition in sugar control was maintained, and other parameters also like lipid profile, they improve significantly. Next slide, please. And these are the daily patterns. I won't go detail. We have seen that these were the 15 days average blood sugar, the median blood sugar level, which was quite okay, and especially after the addition of the glycoside. Next slide, please. Again, this is also the daily pattern. You can see we won't be able to appreciate here with the glycoside, but yes, after glycoside, the results were quite better. Next slide. And this is the glucose pattern. You can see here, initially not well controlled, but later on was well controlled. Yes, there were slightly sugar levels some days which were coming a bit on lesser side, but the variability was quite lesser. So there was a sustained blood sugar level control after the addition of glycoside. Next slide, please. And again, this is again same low glucose allowance settings and the median goal, which was A1C 7%, and you can see it was better, better than maybe earlier. The variability below median was quite lesser in initial days, but later on it improved. Next slide, please. And this we have already seen. So this is daily, and those were all 14 days. But we can just conclude that initial days the variability was quite high, the sugars were not getting controlled. After addition of glycoside, we had better sugar control, good time in range, and lesser variabilities also. Next slide. So this is my last slide, that addition of glycoside led to a potent and durable glycemic control, which we have seen. After 3 months also the sugars were very well controlled, and then there were lesser hypoglycemias also. In just a span of 2 days, the time in range improved drastically to 80% and above. In fact, it was 90%. Modern sulfonylureas against the older sulfonylureas, which had problems of severe hypoglycemias, weight gain, etc. Glycoside has shown effective and durable glycemic control with lot of other pleiotropic benefits also in our type 2 diabetic patients. So glycoside holds an important place in the management of type 2 diabetes mellitus due to its proven lesser risk of hypoglycemias and weight gain compared to other sulfonylureas, and it has got a very favorable CV outcome also. So especially in India, I would say, when we want to control blood sugar levels in a higher means of higher values, sulfonylureas are quite effective, and they are widely prescribed across Asia, and amongst them glycoside is a better choice with good glycemic control and lesser side effects. Thank you.
Thank you so much, sir, for taking out your important time and sharing your knowledge on this topic. I definitely think this session knowledge is going to help all the doctors who have joined on their practice also. Sir, we have received some questions, sir. With all your permission, shall we take these questions?
Yes, please, please, please.
First question is, sir, how should patient selection for sulfonylurea therapy be individualized based on comorbidities and age? Could you please share some of the point on that?
Yes, very good practical point. When we start using sulfonylureas, we have some concerns, especially related to hypoglycemias, weight gain, and uh, kind of uh, problems in brittle diabetic patients, elderly patients. But here I would say sulfonylureas, if used judiciously, definitely can help in all these situations. Yes, we may sometimes in few subset of patients may require more monitoring and a little bit of careful dosing also, but in a whole as I said in my presentation, glycoside has shown to be quite safe. I have not mentioned because of the paucity of time, but there are a lot of studies with glycoside where they have shown that they can be used very safely in cardiac patients, in elderlies, in renal patients, with less chances of hypoglycemia.
Thank you so much, sir, for answering this question, sir. Moving forward, we have another question. Sir, is there any evidence supporting differential cardiovascular outcome among various sulfonylureas?
Yes, we have few trials, and again, because of paucity of time, I did not mention those trials, but I have mentioned in my one slide. Compared to other sulfonylureas, even against glimepiride, glycoside has shown to have better benefits in cardiac reconditioning or the ischemic perfusion, because they are sulfonylureas but they act on different receptors of cardiac myocytes. So there is some extra benefit with glycoside compared to other sulfonylureas.
Thank you so much, sir, for sharing your insight on this question. We will be taking one last question, sir. How
Yes,
frequently
please.
should dose adjustment be considered in long-term sulfonylurea users?
I think at least twice in a year we should get a HbA1c, and based on the HbA1c reports, we may keep adjusting the dose of sulfonylureas according to the patient's target A1c and the comorbidities.
Thank you so much, sir, for answering this question, sir. I hope, sir, I can't see any further question. One feedback from Dr. Shudhanshu. Wonderful discussion. Thanks for sharing this
Thank
case
you.
study.
Thank you. Thank you, Dr. Sudhanshu.
Welcome, sir. And as I can see, there is no further question, sir. With all your permission, shall we conclude this session for
Yes,
today?
please. Thank you. Thank you, Mr. Farzan, and thank you, IJCP, for giving me this opportunity. Thank you,
Welcome, sir.
friends.
Would like to see you in future also with different topic. Till then, take care of yourself, sir. It was great
Thank you.
honor to
Thank
have you.
you. Thank you.
Welcome, sir.